Okay, good evening, everyone, and welcome to the 10th webinar of the Cornea Club. We're starting this new year with a special topic on ocular surface neoplasia by a very distinguished speaker. So for tonight's session, I would like to introduce the moderator of the Cornea Club, Mr. Samir Hamada, who is a consultant corneal surgeon at the Corneoplastic Unit at Eye Bank in East Grinstead. And our speaker for tonight is Mr. Gordon Hay, who is the service director of the ocular oncology and the emergency ophthalmology in Moorfields Eye Hospital. And he's also the deputy director of education at UCL Institute of Ophthalmology. So Mr. Hay will take us through the rather difficult topic of ocular surface neoplasia, and he will share his top tips on diagnosis and management. Mr. Gordon Hay, it's all yours.
Thank you. Thank you very much indeed for the introduction. Thank you so much for the invitation. I've just had a look at the Cornea Club on Facebook and see all these illustrious people, and I'm sure to drag the tone into the gutter. But thank you for the invitation anyway. Lovely to be here. Now, of all my ophthalmology colleagues, the ones that tiptoe around us more than anybody are the external disease team, because sometimes they find things that they sort of wish they hadn't found when something looks like a pingueculum and then turns out to be a cancer. So I think it's important to highlight a few of the most salient features of these ocular surface cancers to you, but also at the end of it, I'll give you some top tips for when you actually make a referral. And in fact, from my point of view, the thing that's most critical when you refer to us is giving us the most important information, preferably with a photograph as well, because it lets us triage things perfectly safely. So I have no conflicts of interest, although I actually have a book. Now, I'm joking about this. I don't actually have a book to sell. I have a book to give away to you. If anybody would like a copy of this, please let me know. Just send me an email, and my email address will be forthcoming. And we put this together not to make any money out of it, but so that it helps all of you who work in ophthalmology guide your own practice, but also helps you have an understanding when you're talking to patients about likely treatment options for various surface cancers. And also, it gives you so much information, it makes your referrals better. And this has been out for over a year now, and we almost immediately saw an improvement in the referrals coming into the service. So if any of you would like a copy of this, there's my email address. So you can watch it back and ping in email. Please put book in the subject, and I will happily send you a copy of our guidelines. So anything else that you want to know, let me know. So the first question that people often ask us is, what's the best way to send tissue to you? Well, attached to the patient is our preferred option, particularly for anything pigmented that's potentially a melanoma. We often have problems with tissue orientation, and it happens once in a while that we see someone who's had an excisional biopsy or an incisional biopsy gets referred to clinic, but the excisional ones are more important because all we see is a denuded ocular surface or a denuded conjunctival. We can't actually see where the base of the lesion was. We can't see how mobile it was. We can't see feeder vessels and so on. So it's much more helpful for us to see tissues before you do a biopsy, particularly with anything that you suspect is a melanoma. There are, of course, things which are not quite as sinister as melanomas, and we're happy to discuss those with you even before you operate if you need to. It gives us also a better idea looking at our own pathology reports, whether they need adjuvant treatments. Our own pathologist expert at looking at margins, depth of invasion. And we often run into pathology problems even when the surgery is expertly done. And I have seen some absolutely beautiful surgical outcomes from colleagues who refer patients, and they think that something might have been an inflamed pingueculum, and it turns out to be an OSSN. So even when the surgery is beautifully done, we still sometimes have problems. So it's always helpful to see the patient before surgery. That being said, as we've got a number of cases from all over the UK, we had one recently where the patient was simply too unfit to come to us from Cornwall. And we were able to offer remote opinions to both the patient and to the local surgeons and give them some top tips on the surgery. So they don't all need to come to London, but if you are concerned, we are happy to advise remotely or to see the patient. Now, the most important thing when removing these lesions is a no-touch surgical technique. This is particularly important for melanomas. We want to try to avoid manipulating the tissue as far as is humanely possible. You can see the picture in the bottom right there. There's a amniotic membrane graft going in, but lots of people would advocate changing the instruments. As soon as you've got the tissue off, change the instruments, and then use a completely clean, sterile set of instruments, just to avoid dropping any stray cells into the rest of the conjunctiva. We've had a number of cases where surgery has been done elsewhere, and we've found lesions appearing in the inferior fornix at a later date. So that is why, particularly for melanomas, we like to see these ab initio before we've had any form of surgery. This is a nice example case here. You can see this one here. So there's quite gross seborrheic blepharitis, lid margin telangiectasis. There's a tiny little bit of pigment, little sliver of pigment there on the lid margin. And I usually like to ask people, how many of you evert lids on every consultation? I know I do, just because I'm completely neurotic and have been doing oncology for 20 years. So even an A&E, if they come in with something different, I'll often flip over the lid. But in the oncology clinic, it's one of these things that's a mandatory part of an ocular oncology examination. So I've just described that case to you, and when I ask an audience face to face, usually about 50% of people will put their hands up and say that they always examine under the lids. And I just wanted to show you that that's the sort of thing that can lurk under the lids. That was referred to as a non-resolving meibomian cyst. I assure you that that is not a meibomian cyst. That is actually a very aggressive melanoma. So it's imperative that you have a little look under the lids. It takes a few seconds. So I'm going to talk to you about categories of conjunctival tumours. Many of these involve the cornea, so I know that you're a cornea club, but there is a significant overlay. So the great majority of benign and malignant neoplasms arise from either the squamous epithelium, associated melanocytes, or the lymphoid cells of the substantia propria. And I'm going to go through those sequentially. Breaking it down still further into melanocytic lesions, we often think of the good, the bad, and the ugly. I stole that from Carol Shields in Philadelphia. So the good, the conjunctival nevus or complexion-acquired melanosis, formerly used to call CAM racial melanosis. The correct term these days is complexion-acquired melanosis. Obviously, epiphysis, the freckle, comes into that category. The bad is primary acquired melanosis, which often begets conjunctival melanoma, and the ugly, frank melanoma. So these are all composed of melanocytes to varying degrees, and they're not always pigmented despite histologically containing melanocytes. And examples of those are freckles or epithelium, complexion-acquired melanosis, nevi, and PAM. And PAM is the one to watch because that's often a precursor for going on to develop melanoma. So there's a fairly typical picture of a common freckle. We don't need to see those in clinic. We do get them referred once in a while, but that's just a common freckle. What we usually do is give the patient a copy of the photograph and send them on their way and tell them to get re-referred if it ever changes. And oftentimes wear a pair of UV protector sunglasses April to October every year. Melanosis, you can tell immediately from this photograph, this is a non-Caucasian patient, so this is complexion-acquired melanosis. It is usually always bilateral, not always to the same degree. You can see in these photographs here that it's a little bit more pronounced in one eye versus the other, but certainly it's present in both eyes. But if it's only in one eye, you just got to ask yourself the question, is this really just complexion-acquired, or is it possibly another process? And non-Caucasian patients do get malignancies on the bulbar surface, so don't use their race. Unlike cutaneous malignancies, people of all colors can get malignancies on the surface of the eye. Complexion-acquired melanosis, it is virtually always benign. We always try and avoid surgery if possible. The only caveat being, of course, if there is a sudden enlargement. I saw a gentleman in A&E yesterday who was absolutely covered in complexion-acquired melanosis. He was late 80s, came from the Caribbean, and he'd been to the dentist who noticed pigment on the surface of his eye, and the dentist told him that he had cancer in his eye and had to come to A&E. And I was able to reassure him that he did not have cancer in his eye, and it's actually very common. There's a nice picture on the left there of an Indian gentleman with some complexion-acquired melanosis. And the photomicrograph of a slide, that's an H&E slide, you can see clearly this lentiginous pattern there. It's slightly undulating, but all of the squamous epithelial cells containing melanin, they are in a single line. So that's very reassuring to see that there's no invasion and no abnormal cells elsewhere. So moving on to the conjunctival nevus, there's a variety of pictures of nevi there. The one on the far right, you can see, the far left, sorry, and on my screen, you can see is largely depigmented. It's slightly gelatinous, yellowy looking, but there's no obvious pigment in there at all. The one in the middle, that's got a mixed picture, sort of clear yellowish gelatinous with some integral pigmented areas as well. And the one on the right is very clearly pigmented. There's a line of pigment around most of the limbus as well there. So those are conjunctival nevi. And we always say that cysts are one of those features which are pathognomonic of nevi. We occasionally will do an OCT scan of a nevus and it shows the cysts quite clearly, even if you can't see them with the naked eye. So they are common. 65% of these lesions will have cysts. You can still have cysts within something more sinister. So they're not pathognomonic of nevi, but they are more common. 85% are pigmented and 15% are non-pigmented lesions. They're often puberty-induced when they appear in the first or second decade of life. They usually enlarge significantly during puberty, and then the growth phase stops. They're usually discrete, variably pigmented, and slightly elevated, usually on the bulbar conjunctiva. And the one thing about these is they're quite easy to manipulate with a cotton bud on the surface. I often put some topical anesthetic on, and we use a cotton bud to manipulate them, and they're not particularly adherent. There's about a 1 in 300 chance of developing a melanoma from these. The one thing that I would say is beware of diagnosing a nevus in the fornix or the tarsal conjunctiva, so that is non-sun exposed areas. You might want to just think about that a little bit more carefully, because it's unusual to get them in non-sun exposed areas. And the other differential, of course, is PAM, primary acquired melanosis, racial melanosis, and that can lead on to melanoma. But the risk of these turning malignant is quite low. So what's the management of them? So excision biopsy, if there is apparent enlargement, in our clinic, we usually just take serial photographs. And if there's no change over a year, we give the patient a copy of the photograph and send them away and get the optician to see them once a year. If there's increasing pigmentation, we will do a biopsy. For cosmetic reasons, it's very rare that we will remove anything for cosmetic lesions, because sometimes they leave scars, and you can remove a small brown patch and leave the patient with a small red patch. So we always say to patients that they don't always look quite as clear as you'd like after removal. But there's no real rush. Around the pubertal period, there's no real rush to remove them, because they usually always settle down. This is an interesting one here. So this is a very small lesion. There's no cysts there, but the interesting thing about this one is you can just see going into the base of the lesion at the bottom of that picture, there's a few little fine vessels. And we wondered if these were feeder vessels. And when we did the cotton bud test with this, it was adherent. Now, this is a fairly small lesion. We were not particularly concerned about this when the patient came to clinic, but we took it off anyway, and we're quite surprised to show that that very small thing was actually an invasive malignant melanoma and acquired melanosis with severe atypia. So that was a lesion that had hitherto been a primary acquired melanosis which had undergone malignant transformation. So despite that looking like a relatively bland lesion, to us, we found that a bit suspicious. So fortunately, we took it off rather than observed, and that patient had beta radiotherapy in addition to topical chemotherapy after that was done. Moving on to primary acquired melanosis. So this usually affects middle-aged adults, usually people who look like me. It may wax and wane. At a young gentleman who had some PAM a few years ago, and he went off to play in an orchestra in Uppsala in Sweden, and the lesion almost completely disappeared because he was getting so little sun exposure in northern Sweden during the time that he was away. It reappeared after a London summer. So they can wax and wane. They can often occur without pigment, and again, they're easily mobile with the conjunctiva. And I can't stress too highly, remember to examine the subtarsal conjunctiva and also have a feel for lymph nodes. The other important thing, having been doing this for 20 years and seen countless medical legal reports, is it's not always adequate just to examine under the lids. You've got to document that you've examined under the lids as well, or at least draw a picture. It takes no time at all, and it can be incredibly reassuring if anything medical legal happens as well. So PAM, primary acquired melanosis without atypia. This is pigment confined to the conjunctival epithelial cells. There's no melanocytic hyperplasia. And it's difficult to distinguish histologically between racial melanosis and PAM without pigment. So it's a fairly bland thing. PAM with atypia, so mild if confined to the basal layer of the epithelium in a single cell lentiginous pattern. This is low risk for melanoma. However, PAM with severe atypia has quite a high risk of turning into a melanoma. This is where the atypical melanocytes are not confined to the basal epithelium. It involves the superficial layers, and you often see pagetoid nests on the histology, and a very high chance of those, 75 to 95% of those progressing to conjunctival melanoma. Those are the kind of things that we really need to see. So this is a fairly typical photograph of primary acquired melanosis. Without atypia, almost 0% chance of forming a melanoma, but the histopathology is critical. We will always send these to the path lab at the Institute for FISH. More modern techniques will be BRAF mutation. That will give us an idea about a subsequent risk of malignant transformation. And of course, one of the problems that we do get is patients who are referred for cataract surgery, who has something like this. Before even going through the limbus with a keratome there, we'd want to do a significant number of mapping biopsies to be absolutely sure that there is nothing malignant in there. And often, if there is any suggestion of any degree of atypia, we will treat that quite aggressively before the patient goes on to have cataract surgery. It has happened infrequently that there has been intraocular deposition of malignant cells inside the eye, but we have had a few cases over the years, so it is probably safer to err on the side of caution with those. So the management is controversial, or up until the last few years it's been controversial. We're getting to a stage of having more agreement on how you manage these. So observation in small flat deposits. So we often will do a biopsy for some flat lesions and a map biopsy for extensive flat lesions. If it is thickened, nodular, or has a blood supply, we will often manage those in the same way as we would for a conjunctival melanoma. So that would be a wide local excision and double freeze-thaw cryotherapy, at least to the base and the edges. Frequently, we will add in some topical mitomycin as well. Moving on to melanoma. Now, I've used these photographs as examples of conjunctival melanoma. I cannot remember the last time I saw something as advanced as this in the United Kingdom. It's very unusual to see things, and the last time I saw one as massive as the ones in the bottom pictures was a patient who was on end-of-life care and just wasn't suitable to come in for surgery. But it's very unusual to see them quite as large and aggressive looking as that in the UK these days. We occasionally get patients turning up from, for instance, South Africa. We had one with a very large lesion a few years ago. So melanoma most commonly arises from PAM. It can arise de novo or from a nevus. The median age is 62 years old, and they often produce pigmented or tan lesions. They can be anywhere. They can also be amelanotic, and I'm just going to show you some pictures of those coming up, and they often have a prominent feeder vessel. There is often, if you look carefully with a bright slit lamp, some surrounding areas of primary acquired melanosis. The reason these are such a problem is that they can recur locally and develop distant metastases. You can end up with orbital recurrence, in which case the patient ends up with an exenteration of the orbital contents, and they metastasize to the ipsilateral facial lymph nodes, brain, lung, liver. And for selected cases, we'll refer to the plastic surgeons for a sentinel lymph node biopsy. There's a 5-year rate recurrence, 26%, 8% will go on to have exenteration, and 16% will develop either local regional metastases. 5-year mortality rate is 7%. Treatment is vastly better, both with surgical treatment, topical chemotherapy, but also modern immunotherapy for these drugs is vastly better than it was a few years ago. Surgery, well, it's difficult. As I mentioned at the very beginning, we really like to see these before they've had any form of surgery, but no such surgical technique, wide margins, partial scleral lamellar dissection, and don't forget to remove the conjunctival and possibly corneal component. We use alcohol debridement for the corneal component, but otherwise you can be left with a pristine conjunctiva, but if there's still disease on the cornea, it's just going to regrow and invade the limbus. We often use at least double freestyle cryotherapy to the margins, and that's the initial surgery to prevent recurrence, metastasis, and depth. Please do not do incisional biopsies in pigmented lesions. We often run into problems when that happens. Closure by direct conjunctival apposition. More commonly, we use an amniotic membrane graft because the margins have been so wide, and they often require a symblepharon ring. Occasionally, if there's orbital involvement, we will need to go on to exenteration. So adjuvant treatment, so topical beta radiotherapy, we've got I'll show you a picture of that coming up, or we've done a few cases with ruthenium plaque brachytherapy recently. Occasionally we'll use proton beam radiotherapy. Topical chemotherapy, we'll use topical mitomycin if there's extensive primary acquired melanosis, and essentially we're trying to sterilize any of the rest of the pigment or pre-malignant potential there. And BRAF testing, we send all the tissue away for BRAF testing these days because that allows us to use immune checkpoint inhibitors, and something like vemurafenib, but there are others available. There seem to be new ones coming out all the time. We also refer these to a medical oncologist for a full workup because these do have a high risk of metastasis. So this is a very nice example here of this gelatinous lesion, corkscrew vessels within it, and there's a feeder vessel at the bottom there. And we didn't quite know what this is. We thought it was going to be somewhere on the ocular surface squamous neoplasia spectrum. And we were quite surprised when that came back as an amelanotic melanoma. This one here, again, this is a really interesting one. This is a Caucasian patient, and you can see here that there's this dilated beefy feeder vessel to the right of the picture. Then there's this sort of gelatinous clear component, and then there's this pigmented component. This is a brilliant photograph from Bertel D'Amato. So they are not always cut and dried, these lesions. Again, this one here, clear gelatinous lesion, pinkish with some intralesional vessels and some surrounding pigmentation. And the picture on the right is a post-surgical picture. You can see some scarring there and dragging of the vessels, and that required a bit of work around the limbus as well. This one here was referred to as 5-6 years ago as a pyogenic, non-resolving pyogenic granuloma. Again, you can see these beefy feeder vessels. Pyogenic granulomata don't normally produce feeder vessels. So this also came back, this gelatinous red tumor came back as melanoma. So just quick bit of reflection, having seen all of those photographs. What do you notice about all of these? And at this point in a live audience, you would all be jumping up and down saying they all have feeder vessels. Occasionally you see benign lesions with feeder vessels, but please assume that if the lesion has a feeder, it's up to no good until proven otherwise. So you can see in all of these that there is a feeder vessel associated with them. I just want to mention sentinel vessels, because again, this is something that we've had from our external disease clinic when they've been seeing someone with what was thought to be ocular surface inflammation. And then they find these vessels, and this is a fairly typical vessel of these sentinel vessels. Sentinel meaning, of course, something which is highlighting an underlying disease. And sometimes when you dilate the pupil, I don't know how many people in external disease clinic actually do dilate pupils, but if you see vessels like that, it's mandatory to dilate the patient, look inside the eye, because sometimes you find tumors like this arising in the ciliary body, and these things are actually feeding this large either iridociliary or ciliary body tumor inside the eye. So please don't ignore them. We do occasionally see completely normal eyes, which just have a slightly abnormal vasculature on the surface of the eye. But you can see this is a sort of duplex system here. So if you see something like that, please have a look inside the eye. This is a patient from an external disease clinic. You can see a beautiful graft there. It's an old graft that's been stable for many years. And this, I think the original thought was this was some scleromalacia, but actually that was extrascleral extension of an intraocular tumor. So again, if you see something like that, have a look inside the eye, or refer to us and we will do it for you. So those are the really nasties. I'm going to move on to the nasties, but slightly less nasties here, to talk about the squamous epithelial lesions. And these range from the benign papillomas, which are pretty common, actinic keratoses, all the way through the spectrum of ocular surface squamous neoplasia, from conjunctival intraepithelial neoplasia all the way to invasive squamous cell carcinomas. Thank you to Mandeep Sagoo for these photographs. So this is a very nice picture of papilloma, and these are fairly common in children. They're often small, multiple, and located in the inferior fornix, although they can actually be located anywhere. In adults, they're usually solitary and more extensive, and they can cover the entire corneal surface, simulating malignant squamous cell carcinoma. They're a benign tumor and occasionally associated with HPV subtypes 6, 11, and 18. That infection is acquired at birth. And what we are interested in as ocular oncologists is to know whether the incidence of these is going to change going forward, since we've been using Gardasil in younger female patients. Young male patients are now being given the HPV vaccine. So it'll be interesting to see if there's any change in the incidence of these in the coming decades. They can be sessile or pedunculated, and you notice fine vascular channels which ramify through the stroma beneath the epithelial surface. That's a lovely photomicrograph of what it actually looks like under the microscope. So the picture on the right is a very typical example of a papilloma, and that's what these vascular channels ramifying through the lesion actually look like under a microscope. That's a fairly high resolution picture, and interestingly, it looks exactly like, that's a papilloma, that's a biopsy proven papilloma. We know for a fact that that's a papilloma, but it actually looks almost identical to a picture that's coming up of an ocular surface squamous neoplasia. So what's the treatment for papilloma? So observation, excision using no-touch technique and cryotherapy alone, or topical interferon. Very occasionally we'll use 5-FU, and even less frequently we'll use topical mitomycin. It is fairly common that these will respond either to topical interferon or occasionally intralesional interferon. But usually they respond pretty well without any particular problems. So taking it up a notch to OSSM, it's a spectrum of disease. We classify CIN 1 to 3 depending upon the depth of invasion. So conjunctival or corneal intraepithelial neoplasia. So that's where the lesion is confined to the surface epithelium. It comes in various degrees of cellular atypia 1, 2, and 3. And you get modification of cell organization and loss of polarity with these cells. Can involve the various thicknesses of the epithelium from the basal layer outwards. And you'll have seen pathology reports mentioning the CIN3. It's analogous to the intraepithelial disease that you see in the cervix. Going up then to the next notch, carcinoma in situ, it's the same as squamous cell carcinoma, but confined to the epithelium. Usually involves a full thickness, but the basement membrane is not breached. So that's the next stage up from CIN3. And of course, the next stage is squamous cell carcinoma, where the basement membrane is breached. Remember, that's one of the definitions of carcinomas. There's a variety of variations of squamous cell carcinoma: spindle cell, mucoepidermoid, and adenoid. We tend to see spindle cell mostly. And these lesions, untreated or incompletely treated, these can evade through the corneoscleral lamella into the anterior chamber, and they can also transgress the orbital septum and invade the soft tissue of the orbit. They tend to be locally invasive. Metastases are very rare, but they can cause mutilating disease if not adequately treated. Just want to show this. We've seen a significant increase in the incidence and prevalence of this particular disease since 1987. And again, this is one of those moments where in a live audience, you'd be jumping up and down. What happened globally in 1987? Well, that's when the AIDS pandemic really kicked off. And again, we'll still see these. We're hoping that with the advent of HAART over the past few years, we'll start to see a reduced number of these, but we still see a significant number of these in clinic. And HIV is not the only risk factor. Any other form of immunosuppression can be a risk factor for this as well. So risk factors: sunlight exposure in any race, HPV, particularly type 16, HIV, or immunodeficiency. And don't forget iatrogenic causes of immunodeficiency, such as methotrexate, anti-TNF drugs, cyclosporin is a particular one. And you would be both surprised and shocked if you saw the number of referrals that we get into the eye cancer service for lesions like this. And nobody has actually checked the patient's drug history. And then we do a drug history, and it turns out that they've had a renal transplant and they've been on cyclosporin for the past 30 years or something like that. So please remember that you are also doctors. Try and take as much of a medical and drug history as you can. So what are the clinical features of these? Well, these lesions usually present at the limbus, the bulbar conjunctiva. They are often gelatinous. Leukoplakia is not pathognomonic, but it's very suspicious of OSSM. You get nodules, particularly when SCC is a diagnosis, and diffuse lesions can masquerade as a conjunctivitis. We get a few referrals from our own external disease team every year for a non-resolving conjunctivitis. So you should assume for every non-resolving conjunctivitis that there may be more going on than you think. They can be pigmented in dark races. The pictures that you've seen thus far tend to be fairly pink gelatinous lesions, but they can also be pigmented in non-Caucasian races. And remember that the squamous cell variant, so that is the frank carcinoma stage, can invade the AC and the orbit. This is a nice picture of leukoplakia. Now, you can find leukoplakia in pingueculae. I have, in fact, seen it in the literature. I've seen it in the ocular oncology textbooks. I don't think I've actually seen it in a non-malignant case in the ocular oncology service, but it's certainly reported, and I know that some of my senior external disease colleagues do see it not infrequently in non-malignant conditions. But if you are seeing leukoplakia, that's another sign just to have your wits about you and ask yourself, is this something that is potentially malignant? This is a beautiful picture of corneal involvement with CIN. I've put a question there at the bottom. What was that managed as? Well, that was a non-resolving herpes simplex keratitis that got referred to as, was seen in our clinic. The patient had had topical antivirals, even given some steroids at one point in time, oral antivirals, non-resolving, and got referred to us. And then with excision biopsy, that was confirmed as a CIN. That's a much more aggressive looking corneal squamous CIN there. This one is actually more typical of the ones that we get referred. So this is a very nice picture of a gelatinous lesion with these corkscrew vessels. Occasionally you see these non-malignant lesions, but if you see anything that looks like a corkscrew vessel, you should assume that that is a pre-malignant or malignant condition until proven otherwise. This is what it looks like when it crosses the cornea. This is a patient who had extensive conjunctival disease, which responded really well to treatment, but unfortunately was left with this residual disease on the cornea, which even now, years later, we still struggle to control with topical chemotherapy. Failed interferon, and I think eventually we went through interferon to 5-FU to topical mitomycin. It was only when we gave him mitomycin that this actually improved. This is a much more serious looking thing there. Came back as CIN3. We were expecting this to be a proper SCC, but actually came back as CIN3. And again, you'll notice these beefy dilated feeder vessels and these corkscrew vessels in the lesion. This is the post-surgical outcome. So that underwent a wide excision with lamellar keratectomy and alcohol in the cornea as well. I think he also had a bit of topical mitomycin afterwards as well. So there's another picture of a conjunctival carcinoma, that is biopsy-proven carcinoma. And you can see that clinically, it's very difficult to differentiate between the lower end of the scale, the CIN lesions, and the more aggressive lesions, so the carcinoma. So we tend to manage them all pretty aggressively. And that's why a dedicated ocular pathologist is essential, so that we can give qualitative information on those. This is a squamous cell carcinoma in an African patient. You notice that this is pigmented, and there's some feeder vessels there as well. And I'll just show you the gelatinous version in non-Caucasian patients, but remember, in pigmented races, these can also look pigmented. And this is another lesion. This came to us about 4 or 5 years ago. I think this was a Moorfields internal referral. And I don't know how clearly you can see on your screens, but there is some leukoplakia there, suggestion of some dilated feeder vessels, a little bit gelatinous looking, extending up to the 8 o'clock to 10 o'clock limbus. And we were pretty sure that this was going to come back from the pathologist saying ocular surface squamous neoplasia of any level, really. But we're quite surprised when this came back suggesting the features were reminiscent of lupus. And lo and behold, we referred this patient to Professor Jawad at the Royal London, and sure enough, the patient had had all sorts of symptoms which hadn't been put together in any logical context going back several years. And it was only this biopsy that clinched the diagnosis and that she started to get the care that she needed. So these are just a few photographs of the more aggressive looking variants. In the UK, we tend not to see them look anywhere near as aggressive as this. They tend to seek care and get referred far earlier than this. But again, because we have an international client base, we do occasionally see people coming from overseas with much more aggressive versions of disease than we'd see in a UK population. So treatment, so for the carcinomas, we use a wide margin, 2-3 millimeters at least. If the deep cornea or sclera is involved, they will need epitheliectomy, lamellar keratectomy, or even sclerectomy. these often need an amniotic membrane graft. We virtually always do at least double freeze-thaw cryotherapy to the base and edges to reduce the recurrence rate. If there's intraocular involvement, oftentimes we'll go for enucleation. And if there is any evidence of orbital involvement, then the patient will require orbital exenteration. This is just a quick word about the treatment here, either ruthenium plaque brachytherapy. This here is a strontium applicator. This is a beta radiotherapy applicator. I think Moorfields is the only place in the UK that actually has one of these. And it can be very effective for patients as an adjunctive treatment to surgical chemotherapy agents, and we will often use these. We often have recourse to, we always have recourse, of course, to plaque brachytherapy or strontium for treatment-resistant cases. So the topical chemotherapy, the go-to drug for these is these days largely interferon. The reason for that is the cost of it reduced dramatically about 5 years ago. It used to be about £1,000 a vial. Now it's less than £100 a vial. And for the fairly thin lesions, they often respond pretty well to either topical interferon or intralesional or perilesional injection. We do very few perilesional injections on the grounds that if we find that it hasn't responded to the topical interferon, we'd usually just go to the next step. And the next step will be something like 5-fluorouracil. Again, if that doesn't work, then we go on to my topical mitomycin. We recently changed providers of mitomycin and tinkered with it with a few scleral melts a few years ago. So we were a bit wary of using topical mitomycin, but the preparation that we've got these days is vastly safer, and we have very few really bad reactions to it. Systemic interferon alpha, we don't actually do that here. Cidofovir, again, we hardly ever use that. That's more of an American concoction. It's very expensive. It's not that it's a bad treatment, it's just very expensive, and we don't really have recourse. It's very rare that we can't get this under control. Just want to show you that picture there. That's a patient who had intralesional injections and topical interferon. It shows you how remarkable the response can be. And what's interesting is that the size of the lesion is largely immaterial. We've got quite a number of patients with really small lesions who hadn't responded well at all to interferon, to more severe drugs, but yet we've got some patients with really large surface tumours that respond brilliantly to interferon. So size is not always relevant when you choosing the drug of choice for these. Sometimes the very large tumours respond beautifully to interferon. Excuse me 1 second. So I'm going to move on to the lymphoid tumours. These are my own particular area of interest. I've always found lymphoma fascinating, particularly lymphoma in the eye. So these have a diffuse, slightly pink salmon patch feature. The salmon patch is the thing that is pathognomonic, and you'll have seen in all the textbooks and all the exam questions. It's often in the fornix. It can be bulbar, and it's often differentiate to differentiate between benign and malignant lymphoid lesions. So clinically, they're very difficult to distinguish. So the benign lymphoid tumours are reactive lymphoid hyperplasia. I'm sure all of you in the Cornea Club will have seen these. And of course, the malignant one is lymphoma. So this is a benign lymphoid hyperplasia. Again, my question is, what was this managed as? So this was managed as a pingueculitis, and we saw the patient. We did an excision biopsy of this, and it came back as benign reactive lymphoid hyperplasia. They often respond quite nicely to doxycycline on the grounds that many of them actually will show that they have chlamydia cytici involved in the pathology. So one of the history questions we always asked is, do you keep birds of any description? Are you a pigeon fancier? Do you have parrots or birds, caged birds at home? You'd be surprised the number of times that people do keep birds. You can, of course, check H. pylori because there is an association with benign reactive lymphoid hyperplasia and H. pylori. Lymphoma. Now, this is a beautiful picture of a bulbar lymphoma. Again, the question I'd ask a live audience was, what was this managed as? This was a painless process, but this was a patient that referred from another hospital, and this was managed as a scleritis. Now, to cause a scleritis that looked as thickened and injected and beefy as that, I would have thought that that would have been agonizingly painful had that been a scleritis. So lesions that look like this, particularly if they are painless, that is fairly typical of a salmon patch. So that is a fairly characteristic picture of a conjunctival lymphoma. This is another conjunctival lymphoma. I think this diagnosis took a little while until somebody did a biopsy of this. This was sort of one of these inflammatory conjunctival chemosis things, conjunctival edema. Patient had been on loads of drops, and there was a concern that maybe it was a reaction to either the drops or the preservative in the drops. But eventually somebody very sensibly did a biopsy, and that came back as a lymphoma. This is a very nice chap that we referred to the medical oncologist. These often express CD20. So we referred him to the medical oncologist to start rituximab. And I saw him a few years ago. I think he'd been midway through the treatment cycle with rituximab with no response whatsoever. So I wandered around to the clinic where the medical oncologist was sitting, and we decided just to abort further treatment. Usually you know very quickly after starting if it is going to respond to rituximab. And instead what we did was referred him for external beam radiotherapy. And that was, I think, 5-6 years ago. He has been in complete remission ever since. These lesions often respond brilliantly to external beam radiotherapist. But we always refer to a medical oncologist because a third of these will go on to have, or be found at a later stage to have, a systemic lymphoma. It is usually a non-Hodgkin's B-cell low-grade lymphoma. Very unusual to get T-cell lymphomas, but we got one this week after not having had one for quite some time. So we refer those to medical oncologists for the medical management. We don't get involved in rituximab or anything like that. I just want to show you this one because it's a really interesting picture. We do get these sent to us once in a while. This is just a lovely picture of a conjunctival arteriovenous malformation. Remember that lots of ocular structures can show AVMs. You can see them on the iris, where we tend to call them iris varices, but this is a lovely picture of a conj AVM. This doesn't really need any treatment at all. So, important history questions. Please, if you're sending patients to us, take a medical history. Let us know about topical immunosuppressive drugs such as steroids, etc., systemic immunosuppression, HIV, do they use sunbeds, sun exposure, and cigarette smoking. And I saw a patient in clinic this morning with his treatment-resistant CIN who fitted virtually every single one of those, a gentleman from South Africa. So please give us as much of information. The other thing that we absolutely love is a photograph. We get so many benign simulating lesions that get sent to us that we don't need to see. Sometimes if a patient's come from the north of Scotland or Cornwall for benign things, if you send a photograph, we will often offer them a remote consultation in the first instance just to get more information, get better pictures, and then decide. So the better imaging that you send us, the better it is for the patient and also for us to triage. Just to recap, we like to see all suspect melanoma unless the patient cannot get to us for whatever reason, in which case we can opine remotely. Bertel D'Amato is fantastic at doing Zoom sessions with the patient and also with the consultant ophthalmologist and giving surgical advice as well. The other thing is our pathology service. It's a national service. It's funded centrally. There is no charge from your own hospital if you do samples. Sometimes there's a mismatch between what the local pathologist says. There's often a difference in classification But if you want a second opinion, by all means, send it on to Dr. Caroline Thong at the Institute or Professor Luthert, and they will happily give an opinion. And finally, do not, under any circumstance, do incisional biopsies for melanomas. So that's a quick gallop through anterior segment ocular oncology. I hope you are all still awake. This is one of the problems you have when you're doing these sessions online, that you can't actually see if people are doing their ironing or they've fallen asleep or whatever. So thank you very much indeed for listening.
Thank you, Dr. Hay. Thank you. This was very, very interesting. Well, I always listen to your talk, talking about ocular surface neoplasia, and always learn new things. So thank you. And amazing how you covered wide area thoroughly, nicely, still simple to make it to understand and remember. So really thank you again. I've got a couple of questions, and then pass to Artemis to ask the question from the audience. I mean, I was interested, you said about important to mark and label the biopsies. Do you have any recommendation, advice, what the best way to mark the biopsies?
So what we tend to do is, on the piece of card that you mount it on, we usually use you can draw on it, but usually you'll indicate on it the number of sutures. So you would say north is 1 suture, south is 2 sutures, and so on, and just annotate it in such a way, annotate both the drawing and using your suture technique, so that the pathologist knows the orientation of the lesion, because sometimes you'll find in these samples that the superior edge of the lesion has got an invasive component and the inferior edge is completely clear. But if you don't know which way round it is, sometimes it's really difficult. So make it as obvious as you can to the pathologist. So the lesion with the sample with 1 suture is the superior border, and 2 sutures is the inferior border. And that way it's usually relatively straightforward. So there's a few questions coming through. Does Cimetidine have any row of ocular surface tumours? Not that I'm aware of, but I may be completely out of date. Anonymous attendee, is it safe to start with Tobradex in suspected cases? If you're suspecting an ocular surface malignancy, then no. Obviously, some of these will come after they've been through a number of external disease consultations. And we find if they're not responding to treatment from your primary diagnosis, don't just plow on. Do a biopsy, unless it's obviously a melanoma. We have had a couple of cases of rip-roaring flares of squamous cell pathology when the patient was given topical steroids. It happened to me a few years ago in something that obviously looked like an inflammatory lesion, and the patient came back a few weeks later with something that was very clearly an ocular surface malignancy. So it has happened to all of us at one time or another. What I would reassure you about, however, is God knows how many prescriptions I write in A&E in my 2 A&E days for topical steroids. I'm talking about 1 or 2 cases in 20 years, so they're actually much safer than you think they are, or the literature might report. But again, to answer your question, if there's any doubt, don't keep ploughing on with steroids, do a biopsy. Mohammed Gawida, when you choose topical chemotherapy versus surgery, do you prefer giving 1 or 2 cycles topical or to debulk the tumor? I think it makes more sense to debulk the tumor as much as you can, unless you're pretty sure that it's a fairly low-grade CIN1. It's usually a good idea to debulk the tumor and then treat. But occasionally, if we see very small lesions, or very elderly patients that can't come for treatment, or for whatever reason you can't do an operation, we will often just treat empirically. But tissue is critical. Rhys Davies, so we usually see them. That's a really good question, Rhys. Thank you for that. So after radiotherapy, we usually see them around 4 weeks later.
Sorry, Gordon, could we ask the question because maybe people don't see the question.
Oh, sorry,
Yeah,
I thought it was coming up in the chat box there. So Rhys Davis has asked, following EBRT for diffuse palpebral and bulbar conj B-cell lymphoma, how long would you wait to assess the full response? I have a young patient who still demonstrates much improved but ongoing conj thickening around 4 months post-radiotherapy. Would he hence be a candidate for retux already, or should we sit tight or even consider rebiopsy? So my advice to that, you often do see a little bit of conj thickening. The chap that I just showed who did external beam radiotherapy, the eye that I showed the photograph of looks absolutely pristine. The fellow eye, it still looks exactly as it did immediately after treatment 5 years down the line. So yes, you can get a little bit of conj thickening. I would monitor with sequential photographs maybe every 12 weeks or so. It is unusual. It is very unusual, Rhys, for external beam radiotherapy to fail. That's the gold standard. That's the sledgehammer to crack a walnut treatment. Had he only had rituximab, I would have been far more concerned. So I would sit tight. And unless you can photo document ongoing thickening, I wouldn't do a rebiopsy at this stage. I don't know if that's helpful, but you can maybe stick a digital thumb up somewhere. Next question was, I need to know what was the management for the conj AVM that was shown in the picture. It didn't require any management at all. We just I think we left that one. Didn't need any treatment. What treatment do you suggest in biopsy-proven reactive lymphoid hyperplasia? Again, doxycycline. Most of those will respond to topical doxycycline. You can try that. Next question, Maha Al-Jundi, who's being very flirtatious. One of the most difficult cases I've seen was a young Indian man, 18 years old, with xeroderma pigmentosa. He had multiple pigmented lesions, both eyes, on the conjunctiva, on the eyelid. He was admitted because he had a big cancerous lesions on his back, and we were consulted to see his eye lesions. What would your approach be to these complicated cases? So these xeroderma patients, they need to be under a national xeroderma pigmentosa unit. I don't know where you're based, Maha, but there's a fantastic xeroderma unit at St. Thomas's Hospital. Most of our cases of XD are also XP are under their care as well. They should also be seen by an ocular oncologist, because these small pigmented lesions frequently are actually very early squamous cell malignancies. So we like to see those in an eye cancer service. So I don't know if you've missed the boat on that one, but firstly, St. Thomas's XP unit, unless you've got one. I don't know if there's one in Wales. I don't know if there's one in Scotland. We use the one at St. Thomas's extensively, which provides a brilliant service, and we see a fair number of these as well in the ocular oncology service. I don't think there's any more questions coming through.
There are some from the chat, actually. There is one asking, is HPV routinely screened in OSSN? Is it a prognostic factor?
We don't routinely screen for it. It's just something that's an association. We don't even ask history questions. Sometimes the patient will volunteer, but we don't do HPV tests on all of these. We just manage them as we find them.
Then there is another question. What is your opinion on intralesional bleomycin for OSSN?
We don't use it so much in the UK. I think they've used it in Liverpool once or twice. It's something that they've used quite extensively in the United States. I've seen before and after photographs. I think it works. We just haven't used it very much in the UK. I think the last UK case I saw, I think it was Professor Hyman in Liverpool, who showed some photographs on a meeting, but don't quote me on that.
Great. I think that's all from the chat. And Rhys Davis is thanking you for the answer.
Thank you. I don't know if that's helpful, Rhys, but there we go. Just my opinion. Could you share your email again? Yes, I will go back right to the beginning and show the email. It's just Gordon, GORDON.HAY3 book@nhs.net. So please put in the subject line book and I will ping it on to you. There we go.
Great.
And hopefully you should all find something of some interest in the book for for adult ocular oncology. There's no pediatrics in this one, but there is there is anterior and posterior segment oncology. So I'm trying to close the chat box.
Gordon, may I ask you just last question? I know
Sure.
we bombard you with question today. This is was very nice session. Would your approach for children be different from adults when it comes to ocular surface neoplasia, regardless?
No, we get very few children, certainly UK-based children. We see very few melanomas. We do get them once every few months. We will get a melanoma in a child. The most common referral in children are pigmented conjunctival nevi, which we will watch. As I mentioned earlier, they tend to grow. Usually there's a spurt around the time of puberty and then they stop, but that's the most common referral. But we do occasionally get other forms of malignancy in children. The thing that concerns us about children, it's unusual in them because they haven't had massive amount of sun exposure. There's usually a genetic factor with them, particularly as someone mentions xeroderma pigmentosa. They have a very significant risk of developing ocular surface malignancies of all descriptions, not just squamous lesions. We've seen melanomas in these patients as well. But no, the approach is try and avoid surgery if possible, but if in doubt, tissue is absolutely critical. Professor D'Amato, who's most of you will have heard of Bertel. Bertel is an absolute whiz, and he says he just doesn't think about them. He will take tissue, and then once he's got a report, then he will do the thinking stage. But that's a huge luxury because he works in an ocular oncology service. We appreciate it's not always cut and dried for people in general clinics or external disease clinics. But we do. Every few weeks, we get a letter from someone saying, I thought this was going to be something simple. This is what the pathology's shown. It's vanishingly rare that we cannot fix things or put it right. But the caveat being, if you're suspecting melanoma, please let us see those before you do any form of surgery. Not always easy because sometimes you do get amelanotic melanomas which masquerade. But if in doubt, let us see.
Thank you so much. And thank you on behalf of Cornea Club and all the attendees. I'll pass it to Artemis if any more questions or to conclude. Thank you.
Thank you. I think we've answered all questions. Thank you so much, Mr. Hay, for the excellent talk. And I think we will renew our date for February with our audience, and we will be in touch soon with our next speaker and the exact date. So thank you, everyone, for being with us tonight. Thank you, Mr. Hay, and hopefully we'll see you soon again.
Thank you so much for the invitation. Happy New Year, all of you.
Happy New Year. Bye.
Bye, everyone. Summer, you owe me a drink.
Definitely. Only one. Two, actually.
Two. Cheers. Bye-bye. Bye.
Bye.
Bye.